This is episode 7 of RetFix and Chill. This is new Maddox, old Maddox, and still Maddox. I'm Nitish Mehta. I practice in New York. We'll go around the room here.
Star Wars Zahid. I also practice in New York and Queens and Manhattan.
I'm Mike Andrioli at Northwestern, and this week we have our special guest, Shilpa. You want to introduce yourself?
Sure. I'm Shilpa Gulati. I'm practicing at New England Retina Consultants in Springfield, Massachusetts. And I had the pleasure of learning from Sarwar and Mike as my retina fellows when I was a resident at UIC.
I believe Sarwar would like to kick us off.
A left eye of a phakic gentleman with a infratemporal detachment. The breaks in this situation are supratemporally, and with close examination, there's no inferior pathology here. So, in this case, I thought a pneumatic retinopexy was a good option for this patient, given the location of the breaks, and he was motivated to position as well. So I injected a 0.6 cc SF6 bubble, and this is immediately the day after the injection of the bubble. You can see I've started to apply the laser. So when I tell these patients, positioning is super important. I have them position face down. I had a nice singular bubble in this situation, and I think we'll discuss some tips and tricks later on how to get a singular bubble and not get some fish eggs. I have them positioned for 4 to 5 hours, and then face down, and then slowly over the next hour position up to the break. So in this case, I was able to do the laser retinopexy. The retina was mostly attached, so I didn't even have to do too much manipulation. And even though the breaks are not fully covered by the gas bubble in this situation, I was able to apply the laser here. So this is after the gas bubble has resolved. You can see that the breaks were actually sort of slit breaks along the vessel.
You typically do indirect laser or slit lamp laser?
I prefer slit lamp laser. My neck can't handle the laser using the indirect. I mean, I can do it. I just prefer. I think you can get a great view with a Mainster or a super quad lens. I find myself often tilting the patient's head on the chin rest in order to get the bubble just into a better position, so I'm not at the border or completely out of the way. And if you've had the patient positioned for a long time, the area is not going to immediately detach after the bubble moves away. It'll stay attached. So that's actually a pretty nice trick. I actually sometimes tilt the patient. They're about 45 degrees on the slit lamp, and it works pretty well. This is another case of more extensive detachment in the right eye. This patient has a singular superior break. Very classic example of a good case for a pneumatic. And similarly, in this case, I actually ended up using a 0.3 cc bubble of C3F8. As you can see, I did get some fish eggs. Fish eggs are not the end of the world. People worry about fish eggs, about these bubbles going subretinal. However, 10 to 15 minutes of face down positioning in the office after you inject the gas bubble, as well as doing this at home, is very helpful. As these bubbles grow, they do coalesce. And the following day, that bubble has already coalesced into a singular gas bubble. And in this case, I had access to cryo, and I do like to do, if I have access to it, I like to do cryo the day of the procedure, because I know that I've gotten the retinopexy in, and if I have the patient positioning to the break, I know that that area is going to remain flat. And thankfully, this patient has done well. Incidentally, they are very upset with the distortion that they're getting, presumably from retinal displacement. But unfortunately, in this case, with autofluorescence, there isn't much retinal displacement. So it's been tough counseling these patients, because this is one of pneumatic retinopexies and scleral buckles are some of the techniques that have been shown to reduce the risk of retinal displacement the best. So these are nice initial cases where the breaks are in a favorable position, where you don't have to rely as much on the positioning, especially after the bubble has achieved its full size. Yeah.
And Sarwar, in general, do you have them steamroll at all? Is there what's your routine? What are you doing? What are you telling them? How's that afternoon going for that patient?
So I tell them to cancel all their plans, and they're going to be positioning face down for 4 hours. I tell them that they can be on their phone. I have them sit at with their head at the edge of the table, with strict face down for 4 hours, 3 if it's not a terrible detachment, and then over the course of the next hour, and this is the hardest part, and we really have to sit there and go through with the patients, like, okay, and then over the course of the next hour, you're going to slowly lift your head 15 degrees, and I have them tilt their head in a way that directs the bubble towards the break, with the idea that some of this fluid will be pushed out. But in some of these younger patients, I don't know how important necessarily. I've seen movement of fluid to a different part of the retina, but I think the most important thing is tamponading the break. Even if there's some residual fluid, that will resolve. And sometimes it takes a few months, as we know, with the buckles.
How did you get that big bubble in for that first patient? So what do you usually aim for, and what is your strategy for paracentesis and injecting gas?
So that first case was an SF6 case. So it's an aggressive AC tap. So I always AC tap the anterior chamber as flat as possible with the 30 gauge needle. Especially, and eventually it can be a little disconcerting to flatten out the AC, but eventually enough liquid vitreous will come forward. But I want the eye as soft as possible because I don't want to have complete obstruction of the retinal artery. So I try to get out at least, the pneumatic experts say try to get out at least 3 over what you're going to inject. But it's hard. The anterior chamber, we learn has 250 to 300 microliters, right? So I try to get at least 0.2. And you do, once you inject the gas bubble, I do that right after. Once you enter the eye, retracting a little bit and then injecting slowly can be very helpful. And as I exit, I typically go over it with a Q-tip.
Phakic status, PVD, do these matter?
I prefer a PVD to be present, but that would be my preference if you asked me about 3 years ago. But it matters less now. I've used pneumatics in patients with hyaloid on. I think I've had good results with the hyaloid still being on. And phakic status, people say that, we should worry a little bit more about micro breaks. I actually like the fact that I can do a more aggressive AC tap. I know I can get a bigger bubble in. And whenever I've done a pneumatic in a pseudophakic patient, I actually do a bit more of an aggressive anterior chamber tap to get a bigger bubble in. And I've had pretty good results so far. I have not been burned with micro breaks elsewhere, especially if it's consistent with Linkoff's rules. Typically, you know where your breaks are. If it's a little bit off from Linkoff's rules, I think scleral pressing at the borders of the detachment can help you find those additional small breaks.
Awesome. So I think we've got 2 great cases that show us kind of the basic tenets of the procedure. We're going to have Mike go next. Do you have a couple of cases to show us?
All right. So this first case is a 51-year-old gentleman that came Saturday afternoon to the ER with hand motion, vision, and a MAC off detachment. Fovea was pretty detached at this point. So this is the configuration of it. Relatively extensive, nothing too crazy. So we had this supratemporal break. It's the only thing I could see at that time. So I did SF6 gas bubble, followed it by laser a day or 2 later. And then in follow-up, he started developing more inferior fluid, even though the macula was reattached. And he had this break infratemporally there. So a fair amount of fluid, infratemporal break after pretty large gas bubble. I think it did 0.5 or 0.55 of SF6. So kind of where do you go from here in this kind of situation?
At this point, I'm probably thinking this patient needs a trip to the OR because of the inferior location of the new break.
Are they phakic?
It's not a great location. It's phakic, yes.
This is a 7 o'clock, 8 o'clock. Where was this exactly?
Yeah, it's about a 7:30. So what I did was I did double bubble. Earlier in my career, I wouldn't have tried this, but I did side positioning. He flattened out nicely. I lasered him, and he's 20/20 without ever going to the OR. So I think this was a case where earlier in my pneumaticing would not have been quite as aggressive with that inferior of a break, but it can be done with a motivated patient. That was a pretty quick one. You want to run through one more here?
Yeah, just how much more gas did you inject?
I think I did another 0.4 or 0.5. It was a pretty big gas bubble. I guess I could have shown one with the gas, but it flattened out pretty quickly.
It's a great outcome. I have not had any good luck with the double bubbles that I've done. I've had to take them to the OR.
I don't do a lot of them, but I do more than I used to. I used to kind of approach it, if they were looking great, just stay the course. And if it wasn't looking good a couple days out, I would just bring them to surgery. But I've been a
Yeah.
little bit more aggressive in trying a little bit more exotic pneumatic positionings or double bubbles. And I've actually had reasonable results. It's not 100%. I never tell them it's going to be guarantee, but I tell them it's 50-50 shot at that point, and I've had pretty good success with it, more than I would expect it to.
And how long did you position them on his side until you were comfortable?
I actually will usually position a patient about 24 hours beyond when I laser them. I think once you laser them, they're pretty much good to go. I don't recall any times where I've been burned where that break reopens after laser. So I think we position a bit longer than we need to. So I think I end up positioning him for a couple more days to get it fully flat and laser, then maybe a day beyond that.
Did you do
This is
LIO laser
OPC.
for this, by the way, for the second break?
Fantastic question. I have both, and I kind of, depending on the situation, do either. I think I did Pascal on this guy,
Gotcha.
but I do think
I'm a little flabbergasted by the slit lamp laser through gas. I almost entirely do LAO. I really don't get good visualization of the slit lamp.
I
It's
find that
the
you
focal
either have to
point is
go
very different.
fully through the gas bubble through somewhat the center, or do it Sarwar said and get it out of the way. It's you kind of one or the other. At the edge of the gas bubble, you get a terrible view. I do think anecdotally, I've had in my last practice offices where I didn't have access to LIO. I think I'd probably have a few % higher success rate with LIO. I think you get a little bit better coverage in some more anterior breaks. Some of these like 3 or 9 o'clock break detachments are so easy to do at Pascal sometimes, just a slit
Yeah.
lamp. It's so easy without the gas bubble in the way. Those are like my favorite pneumatic patients. Like a
Yeah.
temporal 9 o'clock is like my dream pneumatic patient, actually, even more so than a superior break sometimes.
I like LIO in the situation so you can torque the head so that the bubble's out of your way. You can depress and just sort of optimize your view. Have a lot of control that way.
All right, so this was a 59-year-old that had, this was actually his second attachment, his right eye detached a few months prior. This eye came in with an inferior detachment. I did straight vitrectomy at SF6. You can see the laser there. And 3 months out, he was starting to develop fluid. He was actually asymptomatic, but it was a fair amount of fluid there that I didn't love. I thought it was too much to laser barricade person. Any thoughts on this one? You don't believe that you can do pretty inferior breaks, I guess. So I'll show you that you can. This was obviously a little different. It's not a straight pneumatic. This was a partial in-clinic fluid air exchange in the side positioning. I did about a 70% in-clinic fluid air exchange, put him on his side and lasered it. And 3 years later, he still looks good. And he's
Just straight up filtered air.
This one, I think I use diluted SF6. When I do it, that's typically what I'll do. I'll do
Okay.
like a partial fill of 20% SF6, put them on their side. And I've actually salvaged a decent amount of post-vitrectomy or bitbuckle patients as well.
When you say in-office fluid air exchange, do you know that technique that people talk about for washing out post-op diabetic vitreous hemorrhages, where you inject filtered air, and then basically, if you do it infratemporally, once you inject the air and then you let go of your plunger, the pressure will cause the hemorrhage to come out. Is that the kind of thing that you do to get the fluid out?
I do one syringe, and I'll do either 27 or 30 gauge needle. I go straight inferiorly. You can lie them on your side and do it temporally. Then I inject a little bit, pull back a little bit, inject a little bit, pull back a bit. And you can get, there are times where I've done these where you can get close to an 80% fill or so. I try not to get super aggressive. I don't want to do anything silly to the inferior retina. So I don't think I can get full fill, but you can
This
get
is sick.
as much as you need. So you can do it for a vit heme, or you can do it for these types of cases where you're trying to get, you probably need about a 60% fill in my experience to get a pretty good inferior coverage with side position.
Amazing.
So my first case, it's more of a straightforward detachment. So it's a 62-year-old woman who came in with floaters, a couple days of shadow. It sort of seemed to move around. Her vision was 20/30. She had an early cataract and she did have a PVD, but the view was clear. And in this case, there was sort of an 11 o'clock break and just the one. Would you guys do a pneumatic for this patient? Here's her OCT. You can see on the en face that there's some subretinal fluid inferiorly, but nothing in the fovea.
My general rule is if I feel comfortable doing a primary vitrectomy, and they're above in the superior 180, then I will try a pneumatic. And the only question I have on this case is the pathology elsewhere, and I think that's where I get tripped up. If I just put a pneumatic in and they've got holes elsewhere or lattice elsewhere, that's where you could run into trouble.
My biggest criteria for pneumatics is I just don't really love them in young patients personally. So I've done them under the age of 50, but it's usually not my preferred option, and especially under the age of 40.
So for this patient, it was a really good view. I know it looks a little bit hazy because she had some early cortical cataract there on that side, but I thought I could visualize it very well. There's no other peripheral pathology in the fellow eye that made me more concerned that I was missing something in this one, and it really followed Linkoff's rules, so I went ahead with it. It was a pretty straightforward pneumatic. The patient was actually really averse to surgery, so it was worked out well, but then we got fish eggs on the bubble and injection, and I like your trick, Star Wars. So I do 3 to 4 hours of face down positioning very strictly right afterwards if I want the bubble to coalesce. And it works really beautifully. So in this case, she flattened out really nicely, and it ended up being a great outcome. The fluid, she only had 5 days of symptoms. The fluid regressed very quickly, and she was basically flat within 2 days.
Great.
I use the same
How
trick,
big was the
so I
break?
try to be really make sure that where I'm injecting is the highest point in the eye, and go in vertically with my needle. This was bullous inferiorly, so I think I went a little bit in for temporally here, and just had her look up and towards the nose. And I think of it, I visualize it like I'm injecting into a PFO bubble. So by retracting just a little bit and going into your original bubble, in general, I'm able to avoid fish eggs.
Do you inject usually infratemporal? Like, for example, I always inject infratemporal, and I just make that the highest point, unless it's super bolus detachment there. Do you vary it depending on the configuration? What's your preference?
My preference almost always 6 o'clock, unless it looks like this, unless it's bolus in the area where I want to inject.
Do you lay your patients flat? Are you doing this in the office chair or?
Yeah, I'm doing in the office chair. One trick I like is that I'll have them reclined for a little while before I go in. I mean, even 5 to 10 minutes will make a difference, such that things sort of settle back a little bit. And it's just easier to get a view to the breaks, get a view throughout, and make something that's very bolus a little bit less so.
And is it like a quick? Is like I've heard both things. Like you can inject super quick to get a large bubble, or you inject very slow to get a large bubble. So, what worked well for you?
So I inject pretty slowly. I don't want to rush it, and it's worked well for me. How about you guys?
I inject quickly. I've had done a couple things to change my technique over the years. One is going to a 27 gauge, actually, like Sarah was talking about. I think I get less fish eggs using 27 gauge. And I haven't had any issue with the entire gas bubble coming out. Sometimes a little bit will come out. I actually inject before I AC tap. So it's a pretty big bubble. I don't care if a little bit comes out, because that probably means their pressure is going to be too high otherwise. So I'll let it self-relieve it. I used to inject at 6 o'clock, but there's a little data in the literature that suggests there might be higher risks of breaks doing that. So I've shifted to almost always injecting superiorly.
I usually inject pretty slowly, similar to how you inject Shilpa. You have to be comfortable with where you are in the eye with the tip of the needle. I typically go in about 3/4 of the way with the needle and then retract to about, once I start injecting, I go back to about 50% at that point. With 50% of the needle length in the eye, I know that I'm not in the wrong space. I'm not suprachoroidal.
One trick that I've tried in the office is if I actually do see a couple different bubbles or fish eggs, you just kind of flick the surface of the eye. You can actually get those bubbles to like coalesce in that moment. right there in front of you, and that works like pretty well. You just like take the Q-tip in your hand and just pop, just give the eye like a little snap, and the bubbles will come together pretty nicely. When I was a trainee, I used to take a cup of water and just put air and just like actually push the syringe into water and just to see how it works, to like visualize it directly, like what the speeds matter. So any trainees listening, you can try that little trick and just kind of get like a sense of how fast and what these bubbles actually do when they're inside. Now, water is not vitreous. You can maybe find something a little bit more viscous to practice it, but it's kind of nice to actually like, visualize it. Well, and do you have
Yeah,
another
great.
case to share? Or?
Yes, yeah. So, this next case, also a woman in her 60s. She had a growing inferior shadow, but her vision was hand motion. She also had early cataract, PVD. She actually came in with a MAC off RD, 8 to 11 in the right eye with a radial slit-shaped tear at 9:30 and a small horseshoe tear at 10:30. This was from fellowship, and my attending did a pneumatic. He did not do cryo, just did the gas injection on day one, had the patient position, and he had just a single gas bubble. But on post-op day one, she had a significant amount of subretinal gas that had sort of expanded the detachment to involve the superior and nasal quadrants. So it's very bullous with gas underneath the retina. Has that happened to any of you before?
I've had one case where, yeah, like 100% of the gas went under the retina. It was like a decent sized break, but she was like near total detachment, similar like a hand motion. So like, I'll put a little bit more gas in. I'll be careful to inject elsewhere. Maybe I got under the retina or something. Same thing, 100% of the gas went under her retina the second time. So she unfortunately needed surgery, but yeah. What did you do here?
It's happened.
So
I've seen it.
in clinic, there were some maneuvers tried to sort of torque it out of that, torque the eye, have move the head to see if it would emerge, but it did not. So we went to surgery the same day. Okay, so this is the superior view of the right eye, and you can see that we put the trocars initially supranasally, infranasally, and infratemporally, and put the infusion infranasally because we wanted to avoid that very bullous detachment. And the goal is to use the vitrector infratemporally. So here's what it looks like starting out. We're trying to initially
Wow.
torque the eye, and yeah, you can see there's some good views of the gas bubble, but we're trying to stick the vitrector in that subretinal space, torque the eye just by turning it to see if it would emerge. It did not initially. And then we tried some rolling techniques, which actually was really great. We did depress while turning the eye, and by rolling it, it really emerged in a nice way in this all together as one bubble. And you'll see that in a moment.
This is also a good case to try external needle drainage.
Yeah, I was going to say the
Works
That
same.
was
really
the
well
next
for this.
consideration. We were sweating a little bit and thinking about moving to that direction.
Yeah. I
Beautiful,
haven't had to
beautiful
do it
technique.
much for
Yeah, so we,
rhegmatogenous, but I've done it for exudative after melanoma a fair number of times and without any issues.
and so there was still actually a little bit left. And again, we had to roll it out of that break. You can see how much we're pushing on the eye.
Yeah, nice case.
You can see, the unfortunate part is after that kind of presence of gas subretinally, it was a really bullous, mobile retina that we were dealing with. So the air fluid exchange, you can see how much it wanted to move.
Yeah.
Unfortunately, the breaks tend to enlarge quite a bit too in the process.
Yeah, totally.
But
Definitely.
you don't need a drainage retinotomy, because you can get most of the fluid out through the main break.
So I'll finish it up. I have a just one short case that would be nice to share. This is a patient who has like what one of my partners likes to describe as rhegmatogenous syndrome. Just very abnormal vitreous, propensity for tears. The other eye had a retinal detachment that underwent scleral buckle and vitrectomy with an unfavorable outcome. And this is her good seeing eye. We've been monitoring it for the last couple of years. She's, relatively myopic, like a lot of vitreous syneresis, no true PVD. She's already actually developed some peripheral breaks that have been lasered. Good vision, been pretty stable, and she was presented with a hemorrhagic PVD. There was multiple breaks actually. There was a superior temporal, a superior nasal break, lasered it, And then there was this larger pure temporal break here. You can see that there's been some laser attempts around the side here, and she had such a unfortunate outcome with vitrectomy and buckle in the other eye that she was really kind of favoring to do in-office interventions. But at this point, this break is not. There's a fair amount of vitreous traction, and the laser's not holding it at bay. So I actually took it for a sclerobuckle. And so we put a 41 band around the eye. You can see the early cryo marks that are there. This is a non-drainage buckle with good support of the break. But this is like about maybe 3 weeks after the buckle, and this fluid is not going away. And so I wanted to show this case to show that pneumatics have a role sometimes in managing subretinal fluid, even not in the situation of a primary retinal detachment. So we actually put a bubble in and then had her lay on her side and then put some more laser around the break. And you can actually see that it completely put it back. So, my suspicion is that her RPE really wasn't doing a great job at resolving the subretinal fluid despite adequate buckle placement, because you can see now the buckle is actually looking pretty good. So have you guys ever used a pneumatic to sort of support another surgery or sort of help push things in the right direction?
Really well. Harry Flynn did a paper on it for pneumatic salvage of buckles, and he had like a 90% success rate. So I think it's an underutilized procedure for sure.
I like buckles in this kind of patient too, in addition. So I would have wanted to do the same thing, avoid the vit, get the buckle in to support 360, and then go from there. And that was really elegant.
Yeah, great case. I have a question for you guys. If you guys have deemed a pneumatic, have done a pneumatic and deemed it to be a failure, what's your surgery of choice?
If I can get away with the primary buckle, I'll try, but it's not always the easiest thing, like I mentioned. So usually I will do a vit buckle if I can't get away with a buckle. I don't like I said, I don't like re-opping eyes, and I don't think a pneumatic increases the risk of the next procedure failing, but I think it selects for patients that wouldn't have necessarily done amazingly with vitrectomy alone. I do think a decent amount of those failures are pretty abnormal vitreous base, so I don't think a straight fit always solves that.
It's a sign of abnormal vitreous. I mean, especially if it's a Grand Slam pneumatic and it doesn't it fails for some reason. It just increases my concern for redetachment if I were to do a primary vitrectomy. And this has been a change in practice pattern. Shilpa, what about you?
Yeah, phakic status matters to me, and so if they're young, if I look at their vitreous base and it looks like it's just going to contract and pull more, it really depends on how it looks. But if they're pseudophakic, then I try to give them a chance with just a vit.
Shilpa, have you ever tried to use the pneumatic as like a temporizing measure? Mac off detachment comes in, put a bubble in, they're Mac on, your vit's easier. This is something that's been thrown around as a technique du jour. Have you ever tried this?
Rarely. I guess if they were I'm usually just getting them to the OR as soon as I can anyway. But I guess I've done it in a situation where, let's see, they were very recently MAC off, and we can get them to the OR like the next day. And this is just, if for some reason felt super high stakes, then I want to protect the macula and get them back on right away. So I do that. It just depends on, I think, the patient selection. So if they're willing to do it as well, if they are more concerned about regaining that vision as well.
It seems like an elegant way to sort of blend both worlds, where you have this sort of camp that's saying sclerobuckles and pneumatics have better anatomic, outcomes with less displacement versus higher single surgery success with actual parsplanic vitrectomies. So maybe we can sort of blend those two worlds, put the bubble in, protect the macula, and then actually clear out the vitreous.
I think a MAC off patient deserves an in-clinic gas bubble unless you're immediately getting them to the OR. The visual outcomes are so much better with pneumatic, because it's my main procedure to fix detachments. I've seen so many now. I have a ridiculous collection of hand motion of 20/20 patients after pneumatic that you just wouldn't get with doing a vitrectomy 2 days later. I feel like the pivot trial kind of now supports that, but the I do think you get the visual benefit by putting the gas bubble in. Even if you're planning to go to surgery, a day or two later, I think the patient benefits from it.
Cool. Well, that was a lot of fun. A lot of interesting cases, very different techniques, different sort of complications, and also applications of this technique. And so I learned a lot from you all tonight. And thank you, Shilpa, for joining us. And looking forward to the next discussion.
Thanks for having me.